In this next talk, we'll be talking about lower limb injuries. We talk about X-ray findings and treatment options. Have a look at this X-ray. You should try and identify at least 4 abnormalities. You should be able to identify anterior and posterior disruption of the pelvic ring on the left, suggesting an open book fracture. There's also a dislocated left hip. If you look closely, there appears to be a bone fragment in the left acetabular area, possibly originated from the acetabulum or the femoral head. Let's next look at hip fractures. Depending on the level of the fracture, you can differentiate between capital fractures, subcapital fractures, trans or mid-cervical fractures, basal cervical fractures, intertrochanteric fractures, or subtrochanteric fractures. This is relevant as, depending on the level of the fracture, different treatment options are available. Intracapsular fractures usually result in a replacement of the femoral head, with, for example, a hemiarthroplasty, whereas extracapsular fractures are usually fixed with a DHS or a femoral nail. The hip capsule attaches to the intertrochanteric line on the femoral side. Everything above that is therefore intracapsular, and everything below that is therefore extracapsular. One way of identifying neck or femur fractures is looking at Shenton's line. Shenton's line is an imaginary line drawn along the inferior border of the superior pubic ramus and along the inferior medial border of the neck of the femur. This line should be continuous and smooth. This X-ray demonstrates an intracapsular fracture of the neck of femur on the right. You can clearly see a disruption of Shenton's line. Undisplaced fractures may be difficult to diagnose. If there is a high clinical suspicion, further imaging may be required. MRI is the gold standard, but if not available in a timely manner, CT may need to be considered. People with suspected hip fractures should be assessed early. Adequate analgesia should be offered. This may include a fascia iliaca block, consider intravenous fluids, and address any medical problems. Delays in surgery are associated with negative outcomes for mortality and return to mobility. Dislocation in a normal, not operated hip is very uncommon. It is usually associated with high-velocity trauma. It is far more common post-operatively following total hip replacement. Relocation can be attempted in ED under certain circumstances, but should usually be referred to orthopedics. On this X-ray, you can see a left superior pubic ramus fracture. Pubic ramus fractures are common in the elderly. Be suspicious in a non-weight-bearing patient following a fall without fractured neck or femur. Always look into the cause of a patient's fall. Management is usually symptomatic with analgesia. Patients can mobilize as tolerated, but may need admission for rehab. Here you can see a midshaft fracture of a femur. If you look closely, you can see an extension of the fracture to the previously replaced femoral condyles. Like in pelvic fractures, anticipate significant loss of blood. Pain control can be difficult, but traction can be a useful adjunct. Our traction device of choice in ED is the Kendrick splint. A femoral nerve block can also be considered. Here you have got a lateral view of the knee. You may note the high riding patella or patella alta. Distance between the inferior pole of the patella and the tibial tuberosity should be about as long as the length of the patella. These findings indicate a patellar rupture. Often you find an avulsion of the inferior pole of the patella as well. Complete disruption of the extensor mechanism of the knee requires surgical intervention. On this image you can see a laterally displaced patella with a corresponding X-ray on the other side. Lateral displacement is the most common direction of patellar dislocations. To relocate the patella, you extend the knee whilst pushing the patella medially. Following successful reduction, the knee is immobilized in full extension. This can either achieve by applying an above-knee plaster cast or a cricket pad splint. We'll next talk about tibial plateau fractures. They can often be subtle and easily missed. Only a few millimeters of depression or displacement require operative management. The Schatzka classification divides into lateral, medial, or both tibial plateau fractures. This X-ray shows a lateral tibial plateau fracture. The lateral view shows an obvious depression of the plateau. You can also see a joint effusion. It contains a straight line representing a fluid level with lighter fat from the bone marrow floating above and heavier blood at the bottom. This is called lipohemarthrosis. The Ottawa knee rule is a guide to help decide if a knee X-ray is required. It is used for patients above the age of 55. An X-ray is indicated if there's tenderness at the head of the fibula, isolated tenderness of the patella, inability to flex to 90 degrees, and an inability to weight bear immediately and in the emergency department. From here we're moving on to the lower limb. Fibula and tibia are tightly connected by ligaments at the proximal and distal end, and so form a ring. To break a ring, you always have to have two disruptions. This could either be bony or ligamentous. This X-ray shows tibial and fibular shaft fractures. Tibial shaft fractures should always be surgically fixated. Like in all fractures, always check the joint above and below and ensure the distal neurovascular status is normal. Lower limb injuries as well as forearm injuries always have a high risk of compartment syndrome. Remember the 5 P's of compartment syndrome: pain, pallor, paresthesia, pulselessness, and paralysis. We are now moving on to ankle fractures. This X-ray should never have happened, as it shows an ankle fracture dislocation. This should be reduced immediately without the delay of X-ray. The distal tibia is not articulating with the talus on the right. There's also a fracture of the distal fibula. Ensure you check for pedal pulses prior and post reduction. The reduction of this fracture should only be attempted with adequate analgesia or sedation. Even following adequate reduction on check X-ray, an orthopedic referral has to be done. Ankle fractures are commonly classified by Weber. The type of fracture depends on the level of the fracture on the fibular side. It depends on its relation to the syndesmosis. Weber A is a fracture below the syndesmosis, Weber B is on the level of the syndesmosis, and Weber Z is above the syndesmosis. A special type of Weber C fractures is the Maisonneuve fracture. You will find a proximal fibular fracture, a disruption of the syndesmosis, and typically some slight talar shift with disruption of the deltoid ligament medially. This X-ray shows a Weber B fracture with disruption of the syndesmosis and talar shift. This usually represents rupture of the medial ligaments. Ankle fractures may also include a posterior malleolus fracture. In general, the treatment depends on the degree of instability. All Weber C fractures and fractures with talar shift should be considered for ORIF. Don't forget to do a VTE assessment for all these patients. The Ottawa ankle rule helps decide who should get an ankle X-ray. An X-ray should be considered if there is tenderness to this posterior medial or lateral malleolus, tenderness over the base of the fifth metatarsal, or tenderness over the navicular bone, or inability to weight bear both immediately and in the emergency department. This image shows a typical presentation following an Achilles tendon rupture. The patient usually reports that they could hear or feel a snap of the Achilles tendon. This usually results in sudden onset of pain. The patient would be unable to stand on tiptoes. You would usually find a loss of the normal contour with swelling in the Achilles tendon area, and you'd be able to palpate a step within the area of the Achilles tendon. A Simmons and Thompson's test can be performed. Absence of foot plantar flexion on calf compression is interpreted as a positive test result and is indicative of Achilles tendon rupture. Treatment in ED is usually by equinus cast or a special boot. The patient should be non-weight bearing and be followed up by orthopedics to consider operative management. In summary, we talked about pelvic fractures, hip fractures, knee injuries, and ankle fractures. We talked about classifications and indications on when to request X-rays and treatment for a variety of injuries.